You're listening to Medscape's In-Discussion series on cardiorenal metabolic syndrome, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Nihar Desai. Dr. Desai is an associate professor of medicine and vice chief of the section of cardiovascular medicine at Yale University School of Medicine. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Nihar Desai from the Yale School of Medicine. Welcome to Season 1 of the Medscape In Discussion Cardiorenal Metabolic Syndrome podcast series. Today, we're discussing the interplay of social determinants of health and cardiorenal metabolic conditions. I'm absolutely delighted to welcome today's expert guest, my very good friend and colleague, Dr. Erica Spatz, who's an associate professor of cardiology, associate professor of epidemiology at the Yale School of Medicine. She's also director of the Preventive Cardiovascular Health Program and associate director of population health at Yale Medicine. So, Erica, I can't think of a better guest to help us think about the topic today, which is really about social determinants of health and the interplay with cardiorenal metabolic conditions. So in episode 1, we had a very great discussion about some of the key epidemiology, what's happening out there in terms of cardiorenal metabolic health, some of the underlying conditions, the predisposing factors that are all contributing to what we're observing in terms of an uptick in the prevalence of these very important conditions on the cardiorenal metabolic side, both in the U.S. and frankly around the globe. So I really now want to have a discussion with you about how social determinants of health really interplay with that and really underlie many of the epidemiological trends that we are observing. And so I thought maybe for the audience, we could just level set and from your standpoint, maybe just give us a definition of social determinants of health. How do we think about that sort of concept?
We know that to achieve good outcomes for our patients, for our populations, we need to look beyond the medical factors that are directly impacting their care. And this is where we find ourselves in this big world of social determinants of health. And what are they? These are non-medical factors primarily that are impacting health outcomes. The definition that the CDC and the WHO apply is the conditions that people are born into, the conditions in which children are raised, where we work, where we live, our day-to-day lives, and how we age. And when we think about those social conditions, we can think about the family unit, and then we can think about the neighborhood and the community, and then we can think about the policies and the forces that are influencing how we live our lives, what we have access to, be it healthcare or green spaces to exercise. What is the social and cultural contextual milieu that we are living in? And we have learned to codify these and make it clear so that we have some common language and common metrics that we can use to understand the contribution of different aspects of social determinants of health at different levels, ranging from the individual up to the policy level, and then the different factors across those different levels that are contributing to health outcomes.
Let's bring this now into the cardiorenal metabolic sphere as we think about obesity, diabetes, hypertension, cardiovascular disease, chronic kidney disease. Talk to us a little bit about what do we know about social determinants of health and how they impact some of the specific conditions kind of in that cardiorenal metabolic space.
We have a conceptual model for thinking about how these different domains impact cardiorenal metabolic syndrome. So when we think about poverty, what it's like to grow up poor, to have poor access to healthy foods, when we think about neighborhoods and we think about neighborhood violence or noise or safety, right? These social aspects, the conditions where we live, impact us both directly and indirectly. Many of these forces pose direct impact on our inflammatory pathways, stress pathways, our HPA axis is activated. And we know that from the earliest times in childhood, if there's trauma and adverse childhood experiences, that these are leaving biological imprints on people, on children, that are altering their stress pathways, increasing systemic inflammation, activating their amygdala system, and having a direct biological effect. And what is the direct biological effect leading to? It's leading to increased obesity, increased blood pressure. So we're seeing a lot of diabetes, and these are subsequently leading to early heart disease and early cardiovascular events. When we think about the indirect aspects of how these cardiometabolic conditions are increasing, we can think about what it's like to grow up in a food desert. How do we encourage people to eat healthy when those options aren't available? What is the physical exercise opportunities in that community? Is healthcare accessible? Can people get to the doctor for early primordial and primary preventative care? Do they have money to afford medications or to afford programs that support healthy lifestyle behaviors? So we can see that there's direct biological impact as well as indirect impact through health and health behaviors that are impacting cardiorenal metabolic syndrome, epidemiology, and outcomes.
The impact of social determinants of health really can't be overstated. We will not make progress, I think, on the cardiorenal metabolic framework, what our patients deserve, what our communities need, what the country needs, if we're going to get healthier, we're going to deliver better quality, better value care, and we're going to achieve that in a way that is cost sensitive. We're going to have to think about these larger issues, these broader issues, from all the impacts, biological, all the way to care delivery and ultimately to the outcomes that are achieved. And so, Erica, I guess as you think about that, and because you reminded us that social determinants really do have biological impact, that from the way genes are expressed to the way different proteins are interacting to the way that certain conditions are manifesting, I guess one has to wonder that even the CRM kind of framework, as much as I think it is a very positive step for the field to think outside of maybe the realm of just cardiology or just nephrology or endocrinology or these particular conditions, whether that be hypertension or diabetes or obesity or atherosclerotic cardiovascular disease. But the fact that we have to bring them all together to think about common pathways, do you think that the way that we phenotype patients, the way that we think about these different conditions, do social determinants of health have a role to play in that?
Right. I think we're starting to explore those questions about what is the longitudinal impact of having exposure to adverse milieus over a lifetime. When you think about our risk models, we are usually taking one cross-section of time. What's your LDL today? What's your blood pressure today? And we're seeing through studies like the MESA cohort, new approaches to using longitudinal data to understand the result of ongoing exposure to elevated cholesterol, LDL, inflammation, obesity, and recognizing that these cumulative effects, now that's the outcome usually. We have to look a little deeper to say, well, why is that person having elevated blood pressure or elevated LDL, inflammation, glucose? Why is that they're experiencing that? But when we start to see that these longitudinal exposures are actually sometimes more associated with adverse cardiovascular outcomes, we need to think in a more nuanced way. The effect is not going to be uniform for everyone. So it's not to say that necessarily because you grew up in this environment that that's your experience. We know that people respond differently to different adverse events, and we are biologically different, we are socially different, and we need to think about what kinds of metrics are useful so that we can individualize our approach and really identify the people that are at highest risk. We're starting to do that with deconstructing race, which is not a biological genetic variable. It's a social construct. And that is becoming more common in our discourse. And we're saying, well, what is the social construct of race? What is the lived experience? Where is there racism, microaggressions? And how do we disentangle that to understand people's individual experience that then may better capture what that risk is that has been previously bound up in a social variable like race? And so we're seeing now calculators come out like Prevent. Prevent is taking our traditional pooled cohort equation and then adding on the renal and metabolic variables like hemoglobin A1C, like urine albumin creatinine ratio. Great. So we have a more expansive view of what people are experiencing biologically. What does this syndrome look like? But we're also capturing things like zip code, because zip code can tell us a lot. We have good data systems to tell us what, on average, is that environment like. What's the income? What's the educational level? What's the poverty level? What's housing quality like in that environment? And starting to kind of deconstruct that. So again, we can get a little closer to what the phenotypes are for any one individual.
How would one get started? And maybe I'll sort of ask you, in a very focused way, that if a health system or a provider group or those that are involved in health and the promotion of population health, if we wanted to start to systematically capture some elements of SDOH, to your point, that we'll never be able to make progress if we don't systematically characterize and capture these important elements of data, whether that be race, ethnicity, whether that be income insecurity or housing insecurity, or all the other dimensions of SDOH that we know are now critically important when we think about cardiorenal metabolic health. Maybe give us your sense of like, where is the field in terms of starting to capture and really think deep about SDOH and its impact on cardiorenal metabolic health. Let's just focus in on the example of trying to capture some of these data elements.
I think that's the perfect place to start, is that we need robust data systems that help us surveil where are we with social determinants and what's the effect of any intervention. So we need robust data systems. Health systems are getting better at this, recognizing that we need better race and ethnicity variables. These were previously assigned, sometimes by the person at the front office, sometimes by the person's last name. We need people to self-identify, because that gives us some window into how they identify, and thereby what are their likely experiences. It's also becoming more common to capture standardized data around social determinants of health. And CMS has really led the way with this through their Accountable Health Communities effort, which captured 5 domains of social determinants of health. Those included housing, food security, transportation, the most important things that are essential for maintaining health. And what the challenge is like, where do we ask people those questions? Who's asking them? They're sensitive questions. So we need to figure out best practices for doing that. And I know that our health system is actually doing that hard work of piloting social determinant of health surveys so that we have that data on our patients and learning best practices for how to get that information in a respectful, sensitive manner. And then when we ask, we also need to think about, what do we do once we get the answer that, yes, this person is experiencing housing insecurity, they're at risk for losing their home, or food insecurity. So the data are really important. Then we need to go beyond that. It can feel very overwhelming, right, Nihar? Like, we're in the hospital, we're in the clinic, and you're taking care of a patient with complex cardiorenal metabolic syndrome. You're looking at 10 medications that they need to take on a daily basis. We're talking to them about nutrition. We're talking to them about exercise, de-stressing their lives. And it's really overwhelming when you have a person who is living in an impoverished area, living with a lot of neighborhood stressors, including, again, noise, violence, lack of cohesion and social support. Maybe they're socially isolated. These are all different aspects of social determinants of health that are impacting our patients. As a physician, as a nurse, we're not experts in social determinants of health, nor do we have the time, and we're not the most effective. So those partnerships are really critical. We are seeing an emergence of community health workers, and state by state, we're increasingly seeing reimbursement for community health worker support, especially for conditions like diabetes, postpartum hypertension. We're seeing community health workers actually be paid for their services. And I think that this is absolutely necessary if we're going to achieve good health outcomes. We need to address the social determinants of health, and we need to ask the experts in our community how to do that.
Yeah, Erica, I think there's so much there, that I want to kind of extend our discussion with. Maybe I'll pick up on that last point that you were just referencing, which is this idea of who or what is the real clinical care team when it comes to cardiorenal metabolic health. And again, I think in a very narrow, maybe in a very antiquated fashion, the days of that being the physician and the team in the office or in the hospital was kind of where all the focus has been when it has come to cardiovascular health, and probably even when it comes to cardiorenal metabolic health. What do you think the care team of the future actually looks like?
This is where I think the field is going or needs to go. So we have been minded around hypertension, super common, impacting young people and young Black men and women at a disproportionate prevalence. And the health outcomes are also disproportionately poor. And being in the hospital, we're seeing young people come in with advanced cardiomyopathy, end-stage renal disease from preventable, modifiable health conditions. About 5 years ago, we established a hypertension program within our cardiology clinic, serving some of our most needy patients. These are patients that our cardiology fellows are serving who are coming from low-income communities who are experiencing a lot of the social determinants of health. And we're trying to get their blood pressure under good control, because blood pressure control rates are abominable, even for people coming into care, even for people coming into cardiology. Only about a quarter to half of people actually have their blood pressure under control. We started by giving them blood pressure cuffs, having them monitor it at home, and extending our care team to include pharmacists to work with them to monitor their blood pressure at home. And this was working really nicely, but of course you get people who engage and people who don't engage. And the people who don't engage, it's not necessarily that they don't care, but you got to think about what's their capacity to do this. So we had this wonderful opportunity. Some local organizations had a grant from CDC called REACH, which stands for Racial and Ethnic Approaches to Community Health. And they wanted to bring community health workers more into the health system. So taking them out of the community and matching them with healthcare providers. What ended up happening is we ended up screening everybody who came into our hypertension program for social determinants of health. And those who had a need and who were interested in help were matched with a community health worker from a local nonprofit organization. And the beauty of it is that here we're as the cardiologists, the cardiology fellows, working with the pharmacists to help close gaps in care, supported by the community health worker who was addressing all of the barriers to that person, measuring their blood pressure at home, attending visits, taking their medication, really providing the contextual understanding of what's happening in that person's life. Hey, listen, this person's actually struggling, right now, but we're working through this. Let's hold off on making any changes. We're going to get them back after this other thing that's taking priority. So I think that these kinds of teams that include a community health worker, a health advocate, a trusted member of the community who is really providing that glue between the medical team and the patient is critically important. But it's not going to happen through grants. Grants are not going to change this, and it's not going to happen through volunteership. I mean, or it being the right thing to do. It really needs to be supported. And I think our payers are increasingly seeing the value of this and seeing that it's important for their bottom line. If they want a cost-effective strategy to manage cardiometabolic syndrome, they need to think about how they're going to support social determinants of health.
Well, thanks so much for kind of sharing that example, and congratulations to you guys. It's really exciting work, and I think really at the frontier of what we're going to have to do and the important work that's multidisciplinary, that's collaborative, that's community-based, that we really have to engage in if we want to tackle and improve cardiorenal metabolic health. And so, Erica, I think maybe on that very optimistic note about what the work that you're doing, what others are doing, I think just to maybe reflect on this as we close this episode, we're in the midst of this new paradigm. I mean, I think this notion of cardiorenal metabolic health really requiring multidisciplinary, cross-disciplinary care for the patients, that we serve, but also the incredible opportunity that we have because of the epidemiology, the growing prevalence of these conditions. And then, as you kind of nicely taught us, the social determinants of health and how they interplay with all of these factors, and that it's necessary, given the criticality of these factors on cardiorenal metabolic health, that we have to think holistically about, yes, the therapies that we want to administer, the risk stratification that we want to do, but also all the upstream contextual factors that are relevant for a patient's health and their ultimate health outcome from a cardiorenal metabolic standpoint. And so I might just ask you to say closing thoughts or parting thoughts, or do you share kind of that optimism about the important work that lies ahead, but also one that because of the work that you're doing, the work that others are doing, that we are kind of charting this path in the right way, in the systematic way, to make sure that we are incorporating and thinking about social determinants of health as we think about cardiorenal metabolic health at large?
Yeah. There's a groundswell of not just interest, but advocacy in this area. And this social determinants of health used to primarily live in the space of public health or schools of public health or population health. And we are seeing interventionalists, surgeons say, wait a second, us too, because guess what? Our patients, our outcomes are affected by social determinants of health. And so I think that we can do a lot with our communities, but where the real change needs to happen is in the structures and policies that help to start to change the way that our country allocates resources and starts to support all people. So I'm very hopeful that we are moving in the right direction. There's an urgency to this because every day we are seeing the devastating consequences of preventable disease that could have been better had we had better systems and policies in place. So I'm hopeful. I'm also pounding the table that change happens quickly. So it's with partners like you, it's with Medscape bringing attention to these kinds of issues that I think we're going to see real momentum. So I really thank you with a ton of gratitude for bringing attention so early in the broadcast to these very essential, very, very essential aspects of how we address cardiorenal metabolic health for our populations.
Well, thank you, Erica. I mean, I think we couldn't have asked for a better guest and expert to kind of help us think about these important topics. I think you've raised many of the key issues for our audience to be keenly aware of. And obviously, they're going to be hearing a lot more about this, the work that's happening. And as you said, there has to be a sense of urgency around these issues. And so wish you all the very, very best in your endeavors. I think our patients need it. Our communities need it. The health of our nation and the globe, frankly, needs it. And so wish you all the very, very best for that. So for our audience, today we really discussed the interplay of social determinants of health and cardiorenal metabolic health with our terrific guest and my colleague, Dr. Erica Spatz from the Yale School of Medicine. Please take a moment to download the Medscape app to listen and subscribe to this podcast series. Thank you again for joining us. This is Nihar Desai for the Medscape In Discussion Cardiorenal Metabolic Syndrome podcast.
Thanks for listening to Medscape's In Discussion Cardiorenal Metabolic Syndrome podcast series with our host, Dr. Nihar Desai. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on cardiorenal metabolic syndrome.